I don't know whether it's good morning or good afternoon, but hello to everybody, and lovely to see you all here again today. And what a wonderful, wonderful conference we're having. So my job is to introduce the session and chair the session, which is going to be delivered remotely. So, as you know, the name of the session is Beyond the Neurotype, Brain and Body in Autism. And it's going to be delivered for us by Dr. Jessica Eccles. So, Dr. Jessica Eccles is a consultant psychiatrist in the Neurodevelopmental Service at Sussex Partnership NHS Foundation Trust, specialising in adult ADHD, autism and Tourette syndrome. Within that service, she co-leads the world's first neurodivergent brain-body clinic. Having trained in medicine at the universities of Cambridge and Oxford, she completed integrated academic training in psychiatry at Brighton and Sussex Medical School, where she undertook an MRC clinical research training fellowship. She is now a reader in brain-body medicine at the BSMS Department of Clinical Neuroscience, where she leads prize-winning research on a broad range of projects that link differences in the body to a variety of physical and mental health conditions. She is particularly interested in the emerging link with neurodivergence, and she chairs the Neurodevelopmental Psychiatry Special Interest Group of the Royal College of Psychiatrists. She's a passionate educator and committed to public engagement. She hopes to encourage curiosity and challenge stereotypes. So I would be grateful if you would give Dr. Jessica Eccles a welcome, a Congress welcome. So Jessica, without further ado, we will begin. Thank you.
Hello. I'm just going to share my slides. Wait 1 second. Here we go. Slideshow from play from start. So I hope you can see this. So I'm going to be talking to you about Beyond the Neurotype, Brain Body in Autism. So thank you so much for the introduction. You can follow me on at Bendy Brain on X and Blue Sky, and at Dr. Bendy Brain on Instagram. I also, if you're interested in the topic, I have a number of papers and webinars on my Linktree, Bendy Brain. So I'm going to just introduce a little bit about who I am and the big idea, and then talk about how our thoughts and theories about this have evolved through time, the importance of brain-body connections, shadow sides, and reflections on typicality. So I last year became the chair of the Royal College of Psychiatrists in the UK's Neurodevelopmental Psychiatry Special Interest Group. So I work actively in the field of autism and ADHD, both as a clinician and a researcher. But my interest stems from this particular physical condition, which I'm going to talk more about. I'm also patron of a wonderful charities, SEDS Connective and ADHD Aware. So in my adult practice, most of the patients that I see, and it's a non-learning disability service, are female. They may be non-binary. They have many years of psychiatric history, even if they're young. They often have a history suggestive of other neurodivergences, such as dyslexia, developmental coordination disorder, or dyscalculia. And many of them have multiple psychiatric diagnoses, such as eating disorder, depression, anxiety, OCD, a personality disorder label, a query around bipolar or psychosis, trauma, and complex PTSD. Many have body-focused repetitive behaviors, such as skin picking, hair pulling, and where my research comes in, they often have a very complex physical health history and a complex risk profile. And I think that all of these factors, the brain-body factors, autism, ADHD, dyslexia, dyspraxia, dyscalculia, and Tourette's, which we often forget about, all interplay into a complex risk profile. So I have stolen the big idea from Professor Edward Bullmore. Should we drop the distinction between mental and physical health? Now, I know the previous speaker was talking about how in sort of non-Western philosophies, there is much less distinction between the mind and the body. And what Professor Bullmore argues is that this Descartesian distinction holds back research and stigmatizes patients. It doesn't just hold back research. Our entire clinical structures are siloed around this distinction. So I'm just going to ask you if you have, if you could just join this Slido and put in any physical health problems you see or think of in relation to hypermobility. So you just join at slido.com with that QR code and that reference, or you type in, you type in 3485710. Oh, we've got some people typing fibromyalgia. Excellent. We're going to talk quite a bit about fibromyalgia. Ehlers-Danlos, IBS, epilepsy, indigestion, stomach problems, fatigue, gynae problems, indigestion, depression, anxiety, a lot of gastro problems. Oh, hemicrania, burnout, gastro issues, hip pain, anorexia, endometriosis. Wow, loads and loads of things. Skin picking, stomach problems, chronic stress, sleep problems, but we can see that there's a lot of thought about fatigue, IBS, epilepsy. So this is a paper that I referred to during my PhD, and you can see here quite a few of the things that we just mentioned. So things like Ehlers-Danlos, joint hypermobility, soft stretchy skin, stretch marks, hernias, gum disease, easy bruising, resistance to local anesthetics, almost all the gastro problems, gastritis, unexplained abdominal pain, inflammatory and irritable bowel syndrome, Raynaud's phenomena, very important for lots of our patients, especially ones taking stimulants because it can make Raynaud's worse. Menstrual problems, urinary problems, irritable bladder, short-sightedness, squints, temporomandibular joint dysfunction. I know that my mother has this because she can put a whole Scotch egg in her mouth going, ah. So there's definitely some movement there in the TMJ joint. Dysautonomia, which is where I come in terms of abnormalities or differences in the autonomic nervous system. Proprioceptive dysfunction, paresthesia, headache, hyperesthesia, so sensitivity to pain, hyperosmia, smell, and hyperacusis. It says cognitive impairment here, but I think they really mean brain fog. So anyway, what was the query here? This is the condition that that table relates to and that I have been studying since 2009. This slide depicts something called joint hypermobility and has some parts of the Baton scale, which is a frequent scale used to assess hypermobility as part of it. There are also this business and the W position and the yoga pose are all not in the diagnostic criteria. People here heard of hypermobility. Are you confident at recognizing or screening for hypermobility? It's perfectly all right to not be sure. It's reassuring that quite a few people are. Okay. But I think it would seem that probably more people are either not certain or not sure than are confident. So I'm going to teach you a little trick in just a second. Why won't the slides move on? So this diagnosing hypermobility requires a physical examination and taking a related history, and there are diagnostic criteria. But there is a self-report questionnaire designed by Hackham and Graham that has very good sensitivity and specificity for hypermobility. So can you now, or could you ever place your hands flat on the floor without bending your knees? Can you now, or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends or contort your body into strange shapes or could do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? Do you consider yourself double jointed? Now, I want everyone to run through that in their heads and work out how many points of that they score. So I'm just going to leave that up for just a second and then we'll input how many points you score. So do you score 2 or more? Now, there's some very robust evidence in epidemiology that suggests 20% of the population score 2 or more on this questionnaire, and that it's generally slightly more in females than males. Now, we know in autism, for example, that there is a big debate about the gender split, and I suspect that in the future there may be a little bit more of a debate about the gender split in hypermobility, which is generally considered to affect females. And obviously there is important influence of female reproductive hormones on joint laxity. So it looks like more people than we would expect are hypermobile. Being hypermobile is far more than just having flexible joints. It is in fact relatively common. And for some people it can be advantageous. So if we think of Simone Biles and Michael Phelps, it's also linked to a variety of medical issues, like the ones that I just described. And these issues cross systems and involve both the body and brain. And in my mind, hypermobility has been really held back. I mean, there isn't even, in the UK, there isn't even nice guidance or a pathway about hypermobility because of a massive confusion about classification and screening tools. So I describe this as the alphabet soup, and SEDS Connective have made this excellent graphic. There are so many different abbreviations, things like EDS, HSD, PGHSD, GJH, BJHS, PGJH, GJL, HEDS, EDH, SHT, and you kind of almost need a PhD in hypermobility to actually understand what these terms mean. But essentially, they describe the difference between symptomatic hypermobility and just the presence of hypermobility. And if you have flexible joints, then you are more likely and symptoms, then you either in the current nomenclature would get a diagnosis of either hypermobility spectrum disorder or hypermobile EDS. Now, all forms of EDS, of which there are 13 or 14, have hypermobility as a feature, but not all hypermobile people have an Ehlers-Danlos syndrome. And the important thing is that this is a difference in connective tissue. So this, now you'll be familiar with this in terms of a spiky profile. Well, there's a spiky profile of hypermobility. When you've met one hypermobile person, you've met one hypermobile person. Each individual will be differently affected by things like pain, fatigue, anxiety, gut issues, dysautonomia. So what did I learn at medical school about these things, and how does it relate now? So when I was at medical school, I actually, when I was in Cambridge, I learnt about Tourette's from Simon Baron-Cohen, and that's actually something that I deal with almost every week in my clinical practice, is thinking about Tourette's and how it affects psychiatric conditions and risk. When I was in Oxford doing my orthopedics rotation, I was on a ward round, and I was identified by a rehab doctor as having sway back knees. Do you see here about how the knees bend backwards? And I had actually found that very difficult, standing up for long periods of time, standing in operating theatre. I also had a problem of having arthritis from a condition called developmental dysplasia of the hip, clicky hips when people do these tests, and I was in a lot of pain. And he sent me to pain rehab, which is something that I've had to do again this year after a number of brain-body issues. So what did I learn when I came to Brighton and Sussex Medical School? What did we know about hypermobility then? Well, I met the wonderful Professor Hugo Critchley, and he passed me this editorial. He said, "Have you heard of hypermobility? I want you to do a project about it." And this was building on literature from Spain, suggesting a link between anxiety and hypermobility, and purporting to have found a shared genetic locus in a family affected by panic disorder. This has not ever been replicated. At the time, and this I started in 2009, this article had come out in Nature in 2008 by Rodney Graham, the grandfather of hypermobility. He said it was an important but often neglected area with rheumatology, accounting for probably half of all rheumatology outpatients, but only recognised 1 in 20 times. Does this sound familiar in terms of neurodivergence and mental health presentations? He also writes that there are associations with fibromyalgia, chronic fatigue, dysautonomia, gastrointestinal disorders, pelvic floor inadequacy, pain amplification, developmental coordination disorder, and osteoporosis, and an apparent link between certain types of anxiety and phobic disorders. So these group of researchers in Spain, Antonio Balbena and Martin Rocio Santos, they had discovered that if you took 100 people with panic attacks, 70% of them were likely hypermobile, had generalized joint hypermobility compared to less than 20% in the general population. And this is a finding that's been replicated over and over again. So what Professor Hugo Critchley got me to do was to look at 72 brain scans, divide them into groups, hypermobile or not, and these were otherwise well people, and look for differences in brain structure. And we found this, a wonderful result for my first brain imaging study: bilateral differences in amygdala, a part of the brain responsible for fear, emotion processing, and autonomic control. But interestingly, at the same time, we found some things that would relate to what we then thought of as neurodevelopmental disorders. Things like a smaller part of the brain involved in the sense of where you are in space, linked with developmental coordination disorder, and also differences in superior temporal cortex that were also seen in autism. So we write, our findings suggest that processes compromising function in neurodevelopmental conditions may occur in individuals with hypermobility, putatively enhancing vulnerability to stress and anxiety. Now that was back in 2012. I went on to do my PhD, which was really trying to work out what was the contribution of hypermobility to mental health problems in terms of its relationship with autonomic dysfunction, and how do we get from having flexible joints to having a panic attack. So the key seems to be in this idea of something called postural tachycardia syndrome. Now, I don't know, people didn't really mention it in the word cloud, but postural tachycardia syndrome is where you get a heartbeat rise of more than 30 beats per minute when going from lying to standing. The same symptoms, so it causes palpitations, lightheaded, dizziness, can happen after being in a hot environment. So some people have to lie down after a hot shower or hot bath, or after eating a large meal. Now, you diagnose it either on a tilt table, but COVID, actually, about 60-70% of people with long COVID have some form of orthostatic intolerance. May have been worsened by COVID, and there is the NASA lean protocol, which means you can do an active stand. So you just take a pulse oximeter, put it on someone's finger, get them to lie down, and then measure the heart rate, and then see what happens when they stand up. And if you get this rise of more than 30 beats per minute, then it's likely POTS. But the interesting thing is hypermobility. So about 80% of people with symptomatic hypermobility have some form of orthostatic intolerance. Orthostatic means standing up. And if you conceptualize hypermobility as a difference in connective tissue, this affects the vasculature. So if you go from lying to standing, or blood pools in the periphery, such as having a hot bath, you may notice pink feet. Then under the laws of homeostasis, in order to maintain cardiac output to the brain, you have to raise heart rate, and this triggers this entire sympathetic involuntary nervous system response. So when this part of the nervous system works differently, mental health problems are maybe more likely to develop. And we found that in all of the children born in Bristol and Avon in the UK in the early 1990s, that if they were hypermobile at age 14, they were more likely to experience depression and anxiety at 18, and there was a mediating effect of high heart rate. We just published this year a functional brain imaging study, and what was really interesting is we showed that hypermobile participants, so we had groups of hypermobility and anxiety, they showed lower neural reactivity to emotional faces in specific frontal regions. So the control center of the brain, the appraisal and executive center of the brain, not appraising emotional images in the same way. Notably, interaction between hypermobility and anxiety was expressed in the reactivity of a left amygdala, a region implicated in threat processing, and mid-insular, primary interoceptive cortex, the business about what's happening inside our body, where activity was amplified in hypermobile patients with generalized anxiety disorder. Severity of hypermobile in anxious compared to non-anxious individuals correlated with activity within anterior insula. So, why won't this move forward? So the predisposition to anxiety in people with variant connective tissue reflects dynamic interactions between neural centers processing threat and representing bodily state. So we took this a little bit further and we found that there was this autonomic perceptual mismatch. And this is a preprint, and this is a big thank you to all the people who took part in analysing and sorting out this study. It is a long time coming to fruition, but particularly Professor Hugo Critchley and Professor Sarah Garfinkel. We turned those results into my MQ fellowship, which was something called Altering Dynamics of Autonomic Processing Therapy, ADAPT, an intraceptive and psychological intervention to target anxiety in those with hypermobility. Now, back in the day when I was doing my PhD, reading a lot of literature about hypermobility, and there wasn't that much of it, I was struck by these two interesting articles, which you could almost think of as joke articles, a bit like the Christmas BMJ. So this one, in the Journal of Nervous Mental Disorders in 2011, found that joint hypermobility was associated with anxiety and increased chocolate consumption. This one in Rheumatology International found that hypermobility was associated with increased tobacco and alcohol use. And both of these articles posit, was this a way to cope with anxiety? But now, thinking about it in terms of my clinical practice and research findings, I wonder, was this a way of regulating distress from neurodivergence? So there have been a series of light bulb moments in my career, but basically hypermobility seems to be linked to everything. So we have written on connecting brain and body, the transdiagnostic relevance of connective tissue variants to neuropsychiatric symptom expression, variant connective tissue and dysautonomia, that's abnormalities of the flight and fright nervous system, are associated with multimorbidity at the intersection between physical and psychological health. So you remember those findings that were similar to autism? Well, the functional imaging findings, they are very similar to what you see in ADHD, this push-pull between the frontal cortex and the limbic brain. So what have we been learning since all of those days that I was at medical school and doing my psychiatric membership? We have learned that gender stereotypes are complex and a challenge in neurodivergence, that it's really not just boys, bus timetables and fidgeting, that many key elements are not captured well by the diagnostic criteria, such as variable attention, emotion dysregulation, and energy variability. But what is really critical is that co-occurrence is the norm rather than the exception. A massive meta-analysis of, I think, 200,000 people suggested if in patients diagnosed with autism, so autistic patients, nearly 50% of them also have ADHD. And this just, makes us think, what are we doing with our pathways? But not only is co-occurrence the norm with other neurodivergences, there is an overlap with certain physical and mental health issues. And the other thing, as a psychiatrist, that is so important is, although there are all these debates about overdiagnosis and underdiagnosis, we know that autism and ADHD are massively overrepresented in all areas of psychiatry. Probably at least 20% of community mental health patients are autistic, and maybe 40–50% of them have ADHD. So just as I'd done my PhD, and during that project we were looking into the relationship between hypermobility and neurodivergence, bang, this article comes out of Sweden. They have amazing registries in Sweden. And they found that if you had a hypermobility diagnosis, you were more than 7 times likely to have an autism diagnosis, more than 5 times likely to have an ADHD diagnosis. And we finally published the results of my PhD in 2022, finding that joint hypermobility links neurodivergence to dysautonomia and pain. It's now been viewed like 210,000 times or so. But what we found was in the neurodivergent group, which were patients from our clinic who had undergone a hypermobility examination and a physical health questionnaire, that you were 4 times more likely to be hypermobile in the neurodivergent group compared to the comparison group or the general population. And that, as you can see here, the musculoskeletal symptom score and the Baton score, which is the hypermobility score, and the orthostatic intolerance score, much higher in the neurodivergent group. So we put this, so this is just really striking. In our female patients, ADHD, autism, nearly 80% with generalized joint hypermobility, so the presence of hypermobile joints. And on the right, we see symptoms of autonomic dysfunction tracking with the hypermobility score, the number of hypermobile joints, the same with the musculoskeletal symptoms. So we put this all together, and physical health symptoms such as orthostatic intolerance and musculoskeletal symptoms such as pain are more likely in neurodivergence because of underlying hypermobility. So you mentioned in the word cloud about some tricky physical problems, things like fatigue and pain. Well, from hypermobility, I got interested in fibromyalgia, and from fibromyalgia, I got interested in ME/CFS, and from ME/CFS, I got interested in long COVID. And I'm just going to take you through a journey of understanding. So what we did is we got money from Versus Arthritis to look at the mechanisms of autonomic and inflammatory mechanisms of pain and fatigue in fibromyalgia and ME/CFS. So we wanted to compare pain-predominant fibromyalgia patients with fatigue-predominant ME/CFS patients, that's chronic fatigue syndrome, those that had both pain and fatigue and those that had no pain and fatigue. And we brought them into our research facility where they underwent tilt table testing and basic inflammatory markers. And then we brought them into our brain imaging facility where they came in on 2 occasions, randomized, double-blind. One of them, they had a typhoid vaccination, which serves as a mild inflammatory challenge. And on the other time, they had a saline injection. And we did various forms of imaging. And we also did cytokines and something called mRNA transcriptomics. So Kevin and I, Professor Kevin Davis, the Foundation Chair of Medicine at Brighton, Sussex Medical School, in 2021, just as we were in the full height of COVID, we wrote this article on the challenges of chronic pain and fatigue, publishing the first article from this study alongside this, in that we say pain and fatigue are clinically important as they are among the most frequent symptoms reported by patients, particularly to general practitioners. When these are persistent or unexplained, they are associated with poorer quality of life and higher costs. They also pose a diagnostic conundrum and have a significant impact on healthcare utilization. What we explore is commonly associated and possible pathological associations, including variant connective tissue, small fiber neuropathy, mast cell activation, dysregulated inflammatory and interoceptive processes. And basically, if you can, like the spiky profile, if you can pick at each one and try and help someone, you may get somewhere. We also talk about the relationship with postural tachycardia syndrome and possible implications for long COVID. So what we found in the patient group was these 2 baseline kind of blood markers that anyone can do, well, not anyone, but can be done in general practice. ESR, erythrocyte sedimentation rate, and C-reactive protein, clearly different between our patients and controls, with our patients basically on the lower edge of the reference range, but clear water to the healthy controls. So what did we find when we put them on the tilt table? Autonomic change in pain and fatigue. We found in red that the patient's fatigue increased and their pain level increased by tilt compared to the controls. But what was really interesting is people think that fibromyalgia and possibly ME/CFS are central sensitization disorders, that there is some problem with sensitization to pain. But what we found was there was no change in pain sensitivity on tilt. So they were not more sensitive to pain, the tilt was inducing pain. So when we put all of this together in a mathematical model, we find that having chronic pain and fatigue is associated with autonomic induced pain and fatigue because of the number of connective tissue features in joint hypermobility and baseline levels of inflammation. So what happened when we brought them to the imaging centre? One of the things, we also did a hypermobility assessment, obviously, and we found that 80% of the ME/CFS and fibromyalgia patients, in fact, met the old diagnostic criteria for joint hypermobility syndrome. Now, some of the patients had this marker, something called arachnodactyly, which is where you can overlap your thumb and your little finger around the narrow point of your wrist, and when you can protrude your thumb the other side of your forearm, or of your palm. And arachnodactyly literally means spidery digits, describes the long, slender fingers typical of patients with Marfan's. Many clinicians regard arachnodactyly as pathognomonic of Marfan's. However, this view is misleading, as it is a key element of the Marfanoid habitus, which is present in several heritable disorders of connective tissue. Other features include long hands and feet, increased skin stretch, joint hypermobility, and characteristic changes in the physiology of the pectum. So what we found is we did cytokines, and we found if you had ME/CFS or fibromyalgia, the inflammatory challenge induced pain and fatigue because of your cytokine response, but only that relationship was only present in those with arachnodactyly. So IL-6 responsivity links fibromyalgia and ME/CFS to increased inflammation, induced pain and fatigue in the presence of this particular hypermobility feature. We also looked at how different parts of the brain talk to one another, and we found that the more connective tissue features, so that's things like soft, stretchy skin, hernias, prolapses, etc., the greater the number of connective tissue features, the greater the change in how parts of the brain communicate with one another induced by inflammation. So this change in brain talk was associated with a change in symptoms because of the number of connective tissue features in hypermobility. Now, this project, and it's not all completely published yet, was a huge piece of work, and I must say a massive thank you to Prof. Kevin Davis, Prof. Neil Harrison, and Prof. Hugo Critchley. So, having got interested in fibromyalgia and ME/CFS, I was at a conference talking about possible things in long COVID, and I formed a collaboration with Claire Steeves. Now, Claire Steeves headed up the British COVID Symptom Study Biobank, which was generated from Zoe data, which came out during COVID, when Zoe was a COVID tracking app before it became a diet app. And what we found was if you had not recovered from COVID-19, you were 30% more likely. So if you had joint hypermobility, as 2 or more questions on that 5-part questionnaire, you were 30% more likely to have not recovered from COVID. Yes, so individuals with hypermobility are approximately 30% more likely not to have fully recovered. This predicts fatigue level. It is clinically important through its potential impact for understanding and identifying subphenotypes of long COVID for screening and personalised targeted interventions. More generally, greater awareness of joint hypermobility and its extra-articular associations is needed for effective patient stratification and implementation of personalised medicine. Now, it's a bit like autism and ADHD. Not all patients are the same, but it may be that within long COVID, there is a subgroup of patients with hypermobility who experience a particular characteristic problems. So we have that was a predominantly white and female sample that I just reported. So we went into a mixed British and UK sample where we purposefully sampled for a broader range of so more diverse. And what we found was exactly the same, an odds ratio of 1.3 for generalized joint hypermobility, for 30% more likely to develop long COVID, and actually twice as likely if you had extreme hypermobility, which was the presence of joint hypermobility and then some further features such as easy bruising. And what we find is both generalized joint hypermobility and extreme hypermobility are significant risk factors for long COVID. They're a particularly high risk of developing long COVID after an initial COVID infection. Further research is needed to replicate these findings with other data sets and clarify the pathophysiology that explains why people with hypermobility may be at greater risk of long COVID. Now, this paper is available as a preprint and is in press at BMJ Public Health at the moment. So what is the relevance of autism and ADHD to chronic pain and fatigue? Well, with my colleague Lisa Quat and others, we looked in the Alspat birth cohort, and we found that children with ADHD and autistic characteristics reported at age 7 and 9 were twice as likely to experience chronic disabling fatigue at age 18, just even correcting for depression at age 18. So the odds ratio for ADHD, 2.18, and autism, 1.78. Now, these are not diagnoses, these are cut off on screening questionnaires. But interestingly, the same cytokine, IL-6, at age 9 were associated with chronic disabling fatigue at age 18. Inflammation at age 9 mediated the effects of neurodivergent traits on chronic disabling fatigue, and all effects remain significant when controlling for the presence of depressive symptoms. Our results indicate higher risk of chronic disabling fatigue for children with neurodivergent traits, likely linked to higher levels of inflammation, which could be genetic, could be environmental, could be trauma. There are so many things that it could be. The implementation of transdiagnostic screening criteria to inform support strategies to counteract risk early in life is recommended. So Lisa and I have been following this up with a sample in the community and basically found that the presence of chronic pain and fatigue is associated with neurodivergent characteristics, and this is because of the presence of joint hypermobility. This is currently under review. Now, as part of that big mechanisms of chronic pain and fatigue study I described, we looked at transcriptomics. Transcriptomics is messenger RNA, so you have your genetic code. Now, hypermobility, like autism, like ADHD, there is very rarely a single genetic cause, though there is in certain circumstances, such as the rarer forms of the Ehlers-Danlos syndrome. What we were looking at is what is the gene expression profile? What are the molecules and proteins that the DNA is making at any one point? So what we were looking is to see what are the biological processes that these are involved in, and then what is the fingerprint? And if we put that fingerprint into a disease database, what other conditions does it look like? So what we found when we looked at the ME/CFS patients and the fibromyalgia patients compared to the controls is there were differences in gene expression to do with mitochondrial metabolic processes, and that there were 242 differentially expressed genes upregulated in patients compared to controls. When we specifically, in that group, as an overall thing, we look at hypermobility and we look to see what conditions this gene expression profile looks like. It looks like an autoimmune condition. It looks like lupus, dermatitis, eczema. So then after the inflammatory challenge, in the whole group of patients, it's upregulated the NF-kappa beta signaling pathway, which is a key inflammatory pathway. And what we find when we look to see what conditions does this look like, so remember, hypermobility looks like an autoimmune condition, then you throw in an inflammatory challenge, which is a bit like what happens in COVID. We find that it looks like substance misuse, it looks like autism, it looks like bipolar, it looks like ADHD, it looks like hip disease, it looks like epilepsy, it looks like asthma. This has been presented at the a big rheumatology European conference, and I'm going to present it at a Ehlers-Danlos Society conference also. So we've just talked a little bit about a lot of complicated, slightly depressing things that are associated with hypermobility in terms of pain and fatigue. I just want to talk about findings from a general population study that we did, inspired by a collaboration with the film director Nigel Cole, who made Made in Dagenham and Saving Grace, that there were a top-heavy number of neurodivergent, hypermobile, possibly neurotic types in the creative industries. So we did a study and found that hypermobility was associated mathematically with creativity because of neurodivergent characteristics. We followed this up with colleagues Seb Shaw and Lisa Quat, and our wonderful medical student, now qualified as a doctor on academic training in Glasgow. Big shout out to Ben Erin. And he found that for neurodivergent people, creativity was a means of expression, a form of communication, focus, resilience, a way of regulating emotions, and a form of empowerment, a way of thinking differently and finding value. So why is it important to think body-brain? Well, nearly half of neurodivergent individuals surveyed by Embracing Complexity felt that their treatment of mental or physical health symptoms was worse because they were neurodivergent. Previous patient and public involvement work connected by their team tells us that neurodivergent individuals struggle for years to get an assessment and diagnosis for both mental and physical health problems, back to the big idea, feel a strong sense of being dismissed, misbelieved or overlooked when interacting with professionals and institutions, and repeatedly encounter poor understanding and few or no adjustments for their needs within healthcare and education settings. So just back to the beginning, link with emotion. We published last year, or was it this year, that neurodivergent characteristics linked to emotion regulation difficulties because of a sense of uncertainty about where you were in space, and this effect was twice as strong in those with joint hypermobility. And we have upcoming articles under review about these brain body links in bipolar, eating disorder, self harm, and mental health crisis situations. So, just we had that hypermobility spiky profile. Just a little thought about neurodivergence. So, we know that the autism spectrum is unique to individual people. And the previous speaker spoke about the toll of masking. So, do you struggle with socializing? No. After years of intensive study on things like body language, tone, facial expression, eye contact, and psychology, while also observing and copying my peers, I have created an adaptable script to follow. I am good at socializing. Can I socialize with large groups of people? Yes. Do I need bed rest from physical and mental exhaustion after socializing? Also, yes. So, some thoughts on the nature of typicality. For the doctors in the room and the psychologists and the scientists. And if you were in the gifted and talented program at your school in the 90s, how's your ADHD, high functioning anxiety, and perfectionist based procrastination going? Bonus if you are also the oldest daughter. Kids who grew up academically gifted are now anxious adults who have thousands of abandoned hobbies and spiral into self hate whenever they make basic mistakes or they are doctors. There is no in between. So I, in my college role, presented earlier this year on a BBC Radio 4 archive hour. I would recommend giving it a listen. It's got a lot about the history of ADHD. It was called Trouble Staying Still, ADHD's Identity Crisis. And I'm just going to play you a little excerpt.
My retreating into my head resulted in bursts of incredibly productive academic activity. In ADHD parlance, this is known as hyperfocus. Someone whose hyperfocus got her to Cambridge and then through medical exams discovered that they had ADHD in later life. Dr. Jessica Eccles. I asked her what the diagnosis means to her.
I didn't go looking for an ADHD diagnosis. I'm a researcher, and one day I was very heavily involved in data analysis, and I had my elbow in one position all day. The next thing I knew, I was in hospital with a severe infection as a consequence of an elbow swelling that had come about from hyperfocusing on my data. And it turned out that I was quite deficient in minerals and vitamins. And I thought to myself, why is this? And I thought, well, it's because you eat like an autistic 7-year-old. And I then thought, maybe you're an autistic 37-year-old. So I pursued a autism diagnosis, and to my surprise, it turned out that actually I also had ADHD. So it actually understanding that has made a huge difference to how I work and how I organize my day and how I understand my patients.
And as part of that program, we interview my mother, who was diagnosed with ADHD at the age of 72. So wonder how I became bendy, articulate, and ADHD all at once. Listen to me interview my mum. So it's as heritable as height, hypermobility, and often neurodivergence. And I just wanted to share with you a school report. This is from when I was about 12. I am delighted that Jessica continues to enjoy life at school. She brings a lively intelligence and humour to every activity. As some comments here suggest, she must resist any temptation to lose concentration or rely simply upon native wit to see her through. Jessica's originality borders on the eccentric, and it's crazy. This is from social media, how if you get good grades, they just let you raw dog ADHD your whole life. So, strengths, works well under pressure. Weaknesses, doesn't work otherwise. Shout out to everyone who simply cannot work at an even, steady pace and instead vacillates between frenzied hyperwork mode and a near catatonic state of existential dread and avoidance. When the job requires creative problem solving, the NDs are summoned. And I like this. Autism is a lifelong condition often characterized by an inability to bullshit, a pathological need for fairness, a compulsion to help others, an inexplicable need to expose hypocrisy, an excessive tendency to let other people be. There is no known cure. So will this talk change your practice, research, or thinking about ND? I should just say that in the clip, the audio clip, the bendy, the elbow problem was a bendy elbow problem. It was bursitis. That's encouraging. I hope this was fresh information. It won't be to some of you, but it also, in our neurodivergent brain body clinic, we see so many autistic patients, ADHD patients, patients with Tourette syndrome, and they almost all have disabling pain and fatigue, and there are really straightforward things you can do to help with autonomic dysfunction. So I would strongly recommend that people check out the resources in my Linktree Bendy Brain. But they include things from POTS UK, from SEDS Connective, from HMSA, and from EDS UK and America. So a big thank you to all the people who have helped along the way, and particularly Rebecca Dew and Professor Hugo Critchley, and a shout out to the wonderful Jane Green, who is the chair of the charity SEDS Connective, which is particularly for hypermobile neurodivergent people. And a massive thank you to all of the funders and all of the participants and research staff, and particularly Prof. Kevin Davis, Prof. Hugo Critchley, and Dr. Lisa Quat. So please do find out more if you're interested. I have lots of videos on my Linktree, Bendy Brain. Check out for your patients or yourself the EDS UK GP Toolkit, which gives you tools to help manage hypermobility, postural tachycardia syndrome, and mast cell activation in primary care. And hopefully at the beginning of October, we will be releasing the first episode of the Bendy Brain YouTube channel. So please subscribe now. Thank you.
Thank you so much, Dr. Eccles, for that thought-provoking and fascinating presentation. If you were here in the room, you would understand that everybody was just, as the song goes, hanging on every word you said. And I think just to say as well that thank you for the generosity of sharing all of those resources with us. We have a whole repository to go back on and to reflect on and to assimilate all of that information that you have generously shared with us. And I certainly think that it has, well, I think your survey has showed that it is already impacting on our thinking, whether from all of the various stakeholders that are here in the room, educators, parents, medical profession, and so on. I'm not sure if we have time for questions. Can we take questions? If anybody has a question? Oh. We can take questions, okay. Is Dr. Eccles, is she gone?
I'm here.
You're there, good. Okay, we can take questions. So if anybody would like to ask a question, can you please make your way to the microphone, which is to my right here of the podium. Yeah, that's great. Lovely, thank you. We have a question.
Hi there. I'm interested in whether there is a higher, in people who are hypermobile, are they more likely to get autoimmune diseases after a strep infection? Because I have met an awful lot of people, and it wasn't COVID that triggered it, but it was actually strep throat, but I haven't been able to find anything on that.
Well, it's a really interesting question, because it actually also speaks to the whole business about, PANDAS and, the role of strep and other infections. I'm not aware of particular knowledge, but that doesn't mean to say that that it isn't out there. But this link between hypermobility and autoimmunity is really fascinating, and I think it's triggered by something. So we had a PhD student who was just doing a relatively small study on multiple sclerosis, and found that in the 25 patients that she was doing brain imaging for with multiple sclerosis, 80% of them had hypermobility. Now you might think, what is this? But in pretty much every study that we have done, and we've done a fair few now, when you look at the general population, you find about 20% of people seem to have hypermobility. And then when you look at a particular condition, so something like multiple sclerosis or autism, especially if you're looking at women, it seems that about 80% seem to be hypermobile. And I think there's a huge overrepresentation of hypermobility in autoimmune conditions. And we're writing a paper at the moment about it called The Perfect Storm, which is about how do all of these genetic and environmental factors converge to lead to things like exactly what you described, and also to things like long COVID, a whole host of brain-body things.
We have another question, I think. Yes, we have indeed.
Yes, hello. I was wondering if in your research and practice you ever encounter neurodivergent people who, like me, are rather the opposite of hypermobile, more like hypomobile, significant lack of flexibility. Thank you. And what are your thoughts about that?
So I get a lot of questions about that, and I have two answers. One is that I think there is something about neurodivergence and outliers. So it's a bit like, if you're taking a developmental history, we're sort of taught, you should be looking for delayed milestones. But if you see someone who's got very kind of, early milestones, very quick to walk, talk, that might make you think about neurodevelopmental features as well. Now, hypermobility is fascinating, particularly in men, because most of the features of hypermobility in men are not captured well by the diagnostic criteria. So I'm afraid I didn't get a chance to have a look. But if you are a man and hypermobile, what you might find is that you have easy bruising, poor wound healing, long thin face, and a tendency to recurrent ankle sprains, all of which would go with hypermobility. So the current diagnostic criteria don't easily allow it, but the old ones, if you had a number of connective tissue features, you could get a hypermobility diagnosis even without a large number of hypermobile joints. Also, the interesting thing is, because this is a familial trait, people are often like, I am the least stiff person, I am the least hypermobile person I know, I am so stiff. And then you look into it and they still they can still do all of these things. It's just they're used to people who can do more. But there is clearly not all neurodivergent people are hypermobile, but I think it is a significant subgroup.
That's great. Thank you very much. And we have another two questions. So, yeah.
Hi, Jess. Great talk. It's Bianca Comfort from Australia.
Hello.
Hi. I was wondering what your thoughts are on the inflammatory and autoimmune question that you had before and some of the research you've published, and the link maybe with MCAS, mast cell activation syndrome.
Oh, well, this is the interesting thing. So mast cell activation syndrome, for those of you who are not aware, is where you have seem to have kind of hives, rashes, sensitivity. So things like perfume might make you feel sick. Certain additives or washing powder agents might make you, have rashes or itching. Drinking red wine, fermented beer, dark chocolate, they all seem to generate this kind of allergic response. And people with this condition seem to respond well to the combination of H1 blockers and H2 blockers, so drugs like fexofenadine and famotidine. In the world, it is a hugely controversial subject, and I've had immunologists write to me and say, you cannot say that this person has mast cell activation syndrome, that mast cell activation syndrome is a disorder of the internet. But it is something, this pattern is absolutely integral. We see so many people. How many of your patients have a visceral reaction to perfume? I mean, it is just, it's huge. And whatever we call it, the pattern is clear. The immunologists prefer the term chronic urticaria. They seem to be able to get their heads around that. It is absolutely, this is all up for grabs. But the problem with mast cell is that the byproducts that you de facto infer are causing diagnostically, so the tryptase and various prostaglandins and things, they're so unstable and it is so difficult to collect them, and you can only really get them, they wax and wane and they flare, and you have to get the urine on ice and you have to send it to a special laboratory. That it's almost impossible to, at present, with blood or urine, to clinically validate a diagnosis of mast cell. So you kind of need to work empirically. And the great thing in the UK is you can now buy fexofenadine over the counter. And that wasn't the case for many years. But we need so much more research. But the problem is how to. So we've done some research. We've got some symptoms, and we've found some interesting things. But it's like how to actually capture this. So what I would like to do in the next experimental medicine study that we conduct is skin biopsies, and then we look down the microscope and we see the presence of mast cells in the skin. Now, what we know from irritable bowel syndrome is that more than 60-70% of people with irritable bowel syndrome, which is considered to be non-structural in nature, if you actually stain for it, you can find mast cells, massive overrepresentation of mast cells in the gut of irritable bowel, but it's just not the usual stain or what you're looking for. And also in IBS, you've got all this gut motility difficulties, so moving fast and slow, which again, you don't capture down a conventional endoscope. Thanks, Bianca.
Thank you very much. We have another 3 questions, and then we'll close the session because I'm conscious we don't want to go over time. So let's go for it.
Hi there, good afternoon. I just wanted to say I'm really happy to see this talk. I saw you speak at a conference 2 years ago and it absolutely blew my mind, so very happy to be here again. You mentioned earlier about how AFAB people who obviously are dealing with the impact of their hormonal cycles, and that can have an impact on hypermobility. I was wondering if you could just speak to that a little bit more, and if we should be saying that to patients or clients that we're seeing, asking about how their hypermobility symptoms and menstrual symptoms change throughout the month.
Oh yes, no, absolutely, because we know that both, things with ADHD and autism, so sensory sensitivities, impulsivity, emotion regulation issues, they're all affected by the menstrual cycle. And, sometimes they become manifest during, puberty, menopause, all of that sort of stuff, premenopause. And also, they're fluctuating all the time. And if you also, we know that the kind of postural tachycardia syndrome, the physical health symptoms seem to also be fluctuating at the same time. But the thing is it's an absolute, I think it's terrible how little research is done into hypermobility, but how little research is done into the intersection between reproductive hormones and brain-body stuff is absolutely criminal. I think there's one team working in the Netherlands that are doing really great work, but there is so little about it. But actually, my former registrar, Mike, prepared a very good presentation on this. And if you go to our link, to my link tree, there's in the new content, there's a psychoeducation session from our neurodivergent brain body clinic, 23 minutes in, exactly addressing this issue. What we do in clinic is if someone has brain body problems that are exacerbated by female reproductive hormones, we would suggest increasing ADHD meds in the luteal phase, possibly trialing fexofenadine in the luteal phase and possibly more of it. And we would also consider a SSRI just in the luteal phase. But there is some evidence for the SSRI. The other things are really clinical practice, and I can't endorse from an evidence-based perspective.
Amazing, thank you.
Thank you very much indeed. Unfortunately, we're running out of time here, but Jessica, we have 2 more questions. Is it all right for the 2 colleagues to maybe email you and ask you those questions? Because I'm conscious if I take these now, we're going to delay the next session here. But look, just again, I'm really sorry about that, but you can perhaps email Dr. Eccles there. Thank you so much for that. And again, Gurv Mila Mahagut, that in Irish, 1,000 thank yous from us here in Dublin. And I think a final round of applause for Dr. Eccles. Thank you.